to a Z-score, as far as that goes?
Yeah,
Or-
yeah, it's an assessment of how sick the kid is, and the ASA status is the status based on Mal and Patty.
Okay.
It is based on this right here, is how difficult of an airway it is. I believe not how sick the patient is, but I will get back to you after the break on it. I believe this is high risk airway.
Yeah, it's what it looks like.
Yeah, but I will get back to you. There's another one that they look at too to evaluate how sick the kids are. It's again based on adults. I believe it's the New York criteria, but I'll look at that after the break. So essentially, do you delay the intubation in order to wait for gastric emptying? Well, unfortunately, we can't do that because of the patients that we're dealing with. So we can give, let's say, blockade in the stomach. We can give ranitidine. We can give a bunch of things to modify the pH in the stomach, but that needs hours. We can put a nasal gastric tube down and suck everything out, but that has proven that it doesn't help. And largely it doesn't help because where does that tube have to go through? It has to go through the sphincter, the esophageal sphincter, as it goes to the stomach. And normally it's closed. We put a tube down there. What do? We open a sphincter that is protecting us in the first place. So it does kind of seem to be intuitive. Put a tube down, suck everything out, but now we've relaxed the sphincter that ought to be tight. Okay? So basically the rule of thumb is to assume that you have food in the stomach and to do an RSI, and hopefully we mitigate the risks that they were talking about. So based on that, how can we do that? So one of the things that you'll often hear is let's do cricoid pressure. And what I want to also do here is make a differentiation between cricoid and burp. We'll talk about burp a little bit later. When we look at our airway here, our cords are going to be around here. You have your big thyroid cartilage that's shaped like a Roman shield. Below that is your cricoid cartilage. Now the interesting thing with a cricoid cartilage is it goes all the way around, and underneath here is the esophagus. So if I press the cricoid cartilage, what's going to happen is that ring is going to come and butt against the esophagus, and I can theoretically occlude the esophagus by just pressing down on that. That's called cricoid pressure. So basically the thought was, well, we don't know if our patient has food in the stomach or not. We'll paralyze them. We'll jam our fingers on the cricoid cartilage as far back as possible. We'll occlude the esophagus, and guess what? No food can come up. Now that's a really good thought. The problem with that is that there are a few difficulties with that. In the pediatric patient, sometimes figuring out where your cricoid cartilage is difficult, particularly in the neonates. And the last thing you want to be doing is pressing on the thyroid cartilage. Sometimes we are going to get our patient in a suboptimal position by pressing down, and that's not going to help visualize. But the most important thing is this thing called Borhavi syndrome or esophageal rupture. You can imagine that if you have a patient that wants to barf and you are jamming your finger with their cricoid, the amount of pressure that you're causing in that esophagus, and there has been esophageal ruptures reported based on this procedure. So probably not a great idea. Not only that, when I was a medical student, they did a study with doctors in emergency and emergency medical services on their ability to landmark and their ability to apply the proper pressure. And they found that landmarking was a tremendous problem and that people consistently applied way too much pressure. So do not do cricoid pressure because of the way that we can obstruct the airway and we raise the risk of having a Borhavi syndrome. So questions and then we're done.
I have a question for you.
Yeah.
Sorry. And you said it was different, but with intubations, are you okay with a little bit of cricoid pressure for visualization?
So that is burping.
Right.
Yeah, so most people will say, do you want cricoid? Which is different. And we'll talk about that when we're intubating, but that's called burping. And when we burp, we don't touch the cricoid. We have our fingers on the thyroid, and we go behind, up, and to the right. So basically what you want to do is to bring the cords in view. If we apply only cricoid, we shouldn't affect the cords at all. So there is a difference between cricoid and burping, and we'll talk about burping when we talk about getting the airway.
Mad for still calling it cricoid.
Yes, we
Yeah,
always call
like
it
in the
cricoid.
OR, that's just what
Yes,
we call it. But
yes. But that is a completely different procedure, yes. So questions. Pediatric airway compared to the adult airway. True, false? Kids have a smaller tongue in relative to their oral cavity. False. Infants' epiglottis is short and thicker. Okay, yeah. Thicker and shorter, yes. Vocal cords in infants have a higher attachment.
True.
Yes. Children younger than 10 years, the narrowest portion is below the cords. True. Yeah. Okay, so what is the purpose of airway assessment? Why are we assessing the airway? And we're going to repeat this over and over again. Why do we assess the airway? Okay, difficult. We want to rule out kids that may be difficult to intubate. And if we can hand ventilate them. Okay, two biggies there. That's the whole reason why. And you will save probably more lives doing that than anything else, is selecting the proper patients to intubate and finding those that are at high risk. Okay, and that is it. A little bit militant when it comes to capnography. Capnography is a beautiful thing. And we'll talk about why it's a beautiful thing and why we need it on every single patient that we're transporting. So we'll talk about the physiology of how we ventilate. And that's important because capnography is really a measurement on that physiology. And most importantly, we'll talk about how this applies to our transport environment. So there's a few formulas that you need to know. One that we view in cardiac is cardiac output is equal to heart rate multiplied by stroke volume, right? So that's one that you're going to embed in the back of your mind and know forever. This one you don't have to know, but it basically, when we talk about capnography and all the equations, we're talking typically about big A. What's happening in the alveoli as a surrogate of what's happening in the arterioles, okay? So this basically says that we produce CO2. CO2 is released from our blood into our alveoli, and it's kind of dependent on two things. So it's dependent on how much CO2 that we're making, our metabolics, and it's also depending on how our ventilation is. Okay, so really our CO2 is dependent on two things: how we are truly ventilating and how much CO2 are we producing. But you don't need to know that formula. So why is metabolism important? And so this is not a metabolism question, but this is one of the questions I want you to memorize. And we'll go over it. PA is equal to did I do the 0.8? Okay. This is called the alveolar oxygen equation. And when you deal with a sick kid that has a lot of FiO2 requirement, we want to figure out how much oxygen is, how much oxygen is in the alveoli. So, how do we figure that out? This isn't the amount of FiO2 we're giving. What we want to figure out is how much oxygen is in the alveoli. The problem is in the alveoli, there's also CO2. There's also nitrogen gas. There's a whole bunch of other things mixed in. But we tend to focus a lot on oxygen and CO2. So how do we figure out how much oxygen is at the most distal part of our lungs in the alveoli? And this is where this formula comes in. Our FiO2 is easy. It's whatever we dial in the ventilator, right? So let's say it's 0.5. Our barometric pressure is a little bit difficult because we don't typically think about that. But I always think about barometric pressure as 747 because it subtracts from 47 really easy. We could be in Edmonton or we could be in Calgary and the barometric pressure is a little bit different, but it's not going to dramatically affect our final equation. And then what we're going to do is we need to account for how much CO2 is in our lungs. And that's basically where this formula comes in. And let's say our CO2 is 40 and divided by 0.8. Now why is that important? Well, suppose we have done this calculation. We know our FiO2. We can get up on the vent. We're going to figure this wiggle factor out. This 47 is our barometric pressure of water. So we are able to figure this out. We know our CO2 from the gas, and let's say we come up with a PaO2 of, let's say, 400, hypothetically. So we have 400 here, and let's say we do a gas, and the PaO2 of the gas is only 40. Where's the problem? Again, based on this calculation, we have calculated what our alveolar oxygen content is, and like I said, hypothetically, let's say we come up with a number of 400. But when we do a gas, an arterial gas, we find out that we are hypoxemic. What does that tell us? Yeah, it's not crossing here, right? We know that the lesion is around here. Suppose it's 400, and our PaO2, let's say hypothetically, I'm going to throw a random number, is like 380. And yet, on our SAT monitor on our patient, it's 47%. Where's the problem? It's downstream, right? Because we're able to get the oxygen, we're able to load the oxygen onto the blood, and therefore we get a PaO2, but there's something that's happening downstream. So this is where these numbers are really, really important. And so keep this one in the back of your mind. Like I said, there's only going to be 3 or 4 formulas to memorize. This is called your alveolar oxygen equation. And it will help you decipher, oftentimes, if you're struggling, where the problem is. Now, what is this 0.8 all about? You'll see 0.8, or you'll also see multiply. That's why I had to look at that. Multiply by 1.2, which is the same. This 0.8 is basically based on what we talked about earlier, is CO2 production. And what's really cool is, depending on what we eat, we're going to create more CO2. So we are mostly on a mixed diet. But if we have a fat diet only, we are going to be producing different levels of CO2 than if we have a carbohydrate. And you don't have to know what is what, but I just wanted to explain that's where that 0.8 came from. So again, our alveolar oxygen content is based on barometric pressure, how much FiO2 we're giving, and also how much carbon dioxide we're creating. Okay? So why is that important? Again, this is physiology. So when we talk, let's go on to the next one here. When we talk about how CO2 is being passed along in the blood, it's very interesting. There's a number of ways how CO2 is brought back to the lungs. Some of it is dissolved. So when we do a blood gas and we come up with a PaCO2, that is the amount of CO2 that's dissolved directly into the blood, into the plasma. Some of it is bound to proteins, including hemoglobin, so some of it is bound. Some of it is often, or is buffered as well. But if you want to think about it as dissolved, is that the 25% is bound to plasma, and about 75% is on the RBC. And I don't know if you think about red blood cells as carrier of carbon dioxide. I always was taught about oxygen, but in fact, our red blood cells do carry a significant amount of CO2 as well. So then when it gets to the lungs, what happens? And well, it's always what happens, is that we get ventilation happening in a sense that the CO2 is released based on conformational changes of the hemoglobin. It passes through endothelium, a space, epithelium in the lung, and now it's in the alveoli itself. So that's where this comes here. Again, it gets dumped based on gradients, based on conformational changes in hemoglobin, and now it goes into the alveoli, and now we can breathe it out. Okay, so that is basic physiology. So when we talk about a capnograph, capnograph captures this physiology quite nicely. But capnography really captures what is happening at the airway levels, and we're trying to use capnography as a surrogate of actually what's happening in the blood. So our capnograph is a physiologic waveform that looks like this. And in a patient in a steady state will almost look identical from reading to reading to reading. It's non-invasive, obviously. It's a detector that we can put on the endotracheal tube. And really what it's measuring is the amount of CO2 exposure. And we'll explain the various parts of those loops. Now, as you know, we have 23 generations of airways. Generation 18 to 23 is responsible for gas exchange. 18 and above is really a conduit for the air to pass. And you can imagine that the oxygen has a long way to go from the trachea all the way to the most distal 23rd airway. And conversely, your CO2 has to navigate through quite a long maze as well. And it's important to note, though, that these generations, gas exchange happens, and in these airways, these level of airway, it doesn't. And why is that important? Because as we're breathing, so this is at expiration, and now we're letting the CO2 out, what happens is that we get an immediate upstroke of CO2. Now this immediate upstroke that is happening right now is air that is in the upper part of the airways. This is air, CO2 that was probably left behind on the last breath, and now as we're letting the air out, we're letting it out from, first of all, the airways that were not involved in gas exchange. And that's why we get a nice, really quick upstroke. And that's why we're not going to get to our peak numbers, because our peak numbers are only going to happen from air that's happened at the most distal airways as it comes up. So we have an expiratory upstroke. Again, the first initial part of the breath is going to be that CO2 that's in those non-ventilated airway parts. And now finally, as a Gesundheit, as it starts to flatten, that's when we start measuring what's happening at the alveolar levels, those levels of 17 to 23. And as we get further and further along at expiration, we get to a peak. And that is where our end tidal number is being read. And then as we take a breath again inside, or as we take a breath, no CO2 is going across the detector, and it dives very, very quickly. Okay, so that's really our capnography waveform. First, it's the CO2 that was in the non-ventilated areas, and then exposure to the alveolar plateaus. So your reference points again are large airway. We have a little bit in the so large airways, and then again airway that wasn't involved in ventilation, and then there's a transition zone where we get to alveoli, and then level 3 is alveoli only. Okay? So anytime you deviate from this physiologic waveform, you should probably investigate it. This is like an arterial waveform. This is like an ECG pattern. This is physiologic. And anytime that something deviates from this shape here, investigate it, because something may be wrong. So now let's talk about differences, and then we'll talk about the waveforms in specific details as how it correlates to what we're doing in transport. As I mentioned, capnography is a measurement of what's happening at the alveolar levels, at the more proximal airways, and we're trying to use that as a surrogate for what's happening in the blood. But it's not perfect. In a perfect system here, as you can see, we have our CO2 of 46. This is just a schematic. We have a little bit of a gradient that is formed here. CO2 crosses, and essentially in a perfect match, you'll see the numbers are almost identical. There's always going to be a small little gradient, but more or less in a perfect scenario with a perfect end tidal monitor, our end tidal CO2 mimics what happens in reality very, very closely. But there are two scenarios that we need to be aware of, and one of them is a shunt. And what is shunt physiology? What is shunt physiology? Cardiac shunt, respiratory shunt. What happens in a shunt?
Diversion.
Diversion of what?
Blood.
Okay. It is blood that is unable to participate in gas exchange, right? So if we have a cardiac shunt, let's say a big VSD right to left, that is a right to left shunt because that blood on the right side of the heart was unable to go to the lungs. It was unable to ventilate, it was unable to oxygenate. In a pulmonary shunt physiology, for example, what happens is that we have blood that is not capable of gas exchange, it's not able to oxygenate, it's not able to ventilate, because there's something happening at the airway level. What are those things? And I mentioned the most common thing. Well, a mucus plug. If you have a mucus plug here, you're going to get atelectasis, and you have blood that's going to flow that's not going to be able to do gas exchange. Atelectasis is often the consequence of mucus plugging. Or if you put an endotracheal tube in the right main stem, what's happening to that left side? not a whole lot. So now if we look at this schematic, and again, as I mentioned, with a normal perfect end tidal and physiology, our numbers should almost be identical of what's happening in the blood and what's happening with a capnograph. What's happening here is 46, again, our CO2, identical to what our previous diagram happened here. But half of it is unable to participate in gas exchange. This one is fairly normal, that's able to participate. But because now we have mixing with the 46 and the 40, because this was not participating in gas exchange, all of a sudden, look at our difference. Our end tidal is a little bit lower than what's really happening in the blood. And you can imagine that the greater the shunt, the greater the difference between these two is going to happen. Does that make sense to you? Mm-hmm. Okay. Now what is the other kind of extreme? We have shunt physiology on one hand, and now we have alveolar dead space on the other. So what does this look like? Again, a similar schematic, 46, that's what's coming into the single alveolar. Now what happens when now we don't have shunt physiology? This alveoli wants to participate in gas exchange, and it's able to, but we have a problem. The blood doesn't want to participate this time. Why does it not want to participate? Well, a few examples here. Pulmonary embolism. You can imagine if there's a clot right here, what's going to happen, right? Hypovolemia is a common one that we'll see in traumas, for example, where the lungs are underperfused. There's nothing wrong with the lungs, but they're underperfused, and therefore suboptimally are they participating in gas exchange. Cardiac arrest and hypovolemia, kind of a similar dynamic. Hyperinflation, again, is one thing that we often underestimate. You can imagine if we expand this lung and hyperinflate the alveoli, it's going to basically tampen out this capillary so it doesn't participate in gas exchange. So again, what's going to happen here? Your 46 is going to be cut off entirely, right? It can't participate downstream. You're going to have normal gas exchange here, but because this is not participating in gas exchange at all, we're going to have quite a significant gradient. So when we talk about VQ mismatches, V is how we ventilate, Q is our blood flow, and anytime we have a problem with our ventilation blood flow kind of formula, we can't optimally ventilate. Either it's going to be shunt physiology, it's going to be dead space physiology, or it's going to be a combination of the both. Okay?
So Craig, we
Yes.
talked about this morning a little bit, and just like for the cardiac
Yep,
kids,
yep.
so like pulmonary hypertension,
Yep.
or like shunt, actual shunting.
Yeah.
Would you, because we use the word shunt, but we're talking more about pulmonary shunt, would that be more of a dead space issue versus the shunt?
In pulmonary hypertension? So pulmonary hypertension can manifest in several ways.
They're both shunts. One's a cardiac shunt and one's a pulmonary shunt.
Oftentimes, Steph, so we go, again,
They're both examples of blood bypassing the area for gas exchange. One is because it's bypassing the lung altogether, and the other one is it's bypassing units of the lung.
Right.
They don't have that.
so again, my giftedness you can see here. RA, RV, LA, LV. So in pulmonary hypertension, you have a lot of potentials for shunt physiology. If we increase the pressures here because of pulmonary hypertension, a lot of the kids, Glenn physiology, they keep the ASD, VSD open for pop-off. As this pressure goes up, these pressures go up, pressures in the RA go up, and we have a shunt right to left across a ASD or a VSD. That's oftentimes the most common thing. Or we have Glenn physiology here as well, where we have pressures that increase and we have a shunt. So if we have a raise in pulmonary pressures, that gets transmitted to the RV or RA level, and if we have a hole in the heart, that's going to push the blood forward. When we do not have any intracardiac shunts, for example, probably the best way to think about pulmonary hypertension is hypovolemia, in a sense that we cannot get forward flow because the hypertension is so great. And we have lungs that oftentimes are able to participate in normal gas exchange, but they're not getting the perfusion necessary because we can't get enough bulk flow to that. So that's more or less a hypervolemia type picture of pulmonary hypertension, but good question. Yeah. Okay. So when we think about dead space, again, we have anatomic dead space. So again, as I mentioned, there's 23 generations of airway. Number 1 to 16 are not participating. So every one of us has intrinsic dead space. We can have alveolar dead space as well, depending. If you put me on the table and jump up and down on my chest, you're going to probably cause a cardiac arrest, and therefore you can basically induce alveolar dead space in me. And then of course from an RT perspective, there's also dead space in the fancy machines that they plug into the wall. So when you think about dead space anatomy, we can't do anything about the anatomic. That's intrinsic into who we are. Our RTs can do some adjustments on the dead space in their machine, sometimes cutting the endotracheal tube and all the tricks that I don't know about. The alveolar dead space, these are the things that we can modulate at the bedside. If it's a pulmonary embolism, what is that required? Well, maybe we have to modulate PEEP a little bit. Maybe we have to give volume. If it's hypovolemia, volume. If it's cardiac arrest, stop the cardiac arrest. If it's hyperinflation, maybe we have to do less PEEP and lower mean airway pressures. So that's why this is important. This is the thing that we can modulate the most. For the kids that are on the edge and small neonates, mechanical dead space is also very, very important as well. Okay? So clinical pearls, and then we'll talk about why they're pearls. All intubated patients, absolutely every single one that you pick up needs continuous ventilatory monitoring. Changes in end tidal are usually somewhat indicative of what's happening in the blood. Like I said, we're using end tidals as a surrogate. They might not be 1-to-1, but if you're on transport and all of a sudden the end tidals go from 40 to 70, something is going on. And if it's happening at the blood level, we have to figure that out. Very important too, as I mentioned, end tidal is just a number to us. What's important is what's happening in the blood. And very, very early on, we have to figure out how closely related these are. And why is that? Because we can get an idea about the amount of VQ mismatch that is happening. But we have to, when we start end tidal, we have to have a starting point of what the PaCO2 is. If there is something that happens acutely, either the patient becomes hypovolemic, hypotensive, end tidals go sky high, it's probably not a bad idea to repeat what's going on in the blood, because as I mentioned, the blood is gold. So continuous, we'll talk a little bit about this, the safety of it. The best way to detect an accidental or an unplanned extubation is a change in the end tidal, not in your SAP monitor. And that's why it's so important on transport. It's your safety net. So let's look at the normal capnograph or capnogram. As we talked about earlier, it's a physiologic waveform. It's almost identical from breath to breath. And if you understand where it's coming from large airways, transition zone, alveoli, and then inspiration, it kind of makes sense. And you can play around with your time. This capnograph means absolutely nothing to me. Make it so that you can slow down the speed so that you can see a few waveforms at a time. So what if the end tidal levels are raising over time? Now there's a possible causes for that. The first thing I always look at when I'm looking at a capnograph, is it physiologic or not? And you notice that these are more or less the same, but you can notice that the end tidal is getting a little bit higher. So physiologic, physiologic, physiologic. Well, why is this happening? Why is the CO2 going up? Well, maybe we have a problem with ventilation. Maybe we're hypoventilating. Maybe the CO2s are climbing up because the patient is febrile now. An increase in metabolic rate, maybe the medications that we're giving, like epinephrine that we talked about, that raises the metabolic rate by up to 29%. So we see this trend, and this is a difficult trend to see. You can obviously see it here. This is where the number is very important, where maybe you started and it was maybe 35, and halfway through the transport now it's 47, but it happened gradually. We have to figure it out. What's happening? Where is the adjustment? If the patient is febrile, well, you got to address that. If the patient is hypoventilating, maybe you have to adjust the rate a little bit. How about decreasing end tidal? Again, the first thing I look at is I look at the capnograph. Is it physiologic or not? Well, yes, it is physiologic. It all makes sense, but the end tidal is now dropping. Well, why is that possible? Okay, why am I blowing off more CO2? Why is my end tidal lower? Well, hyperventilating is the most common cause of it. Maybe our respiratory rate is a little bit too quick. Maybe our patient is 27 degrees. I just audited a case the other day of a neonatal patient and very difficult airway. And by the time all was said and done, the patient was 28 degrees. Well, that's a really good reason. Are you going to all of a sudden hypoventilate that kid, or are you going to warm the kid up? Methinks probably it's good to warm up the kid and see what happens. Maybe there's a decrease in metabolic rate. Maybe it was a drowning. Maybe the medications that you're giving. Maybe this kid is brain dead, for example. And we see that sometimes when our patients are brain dead and they have absolutely no metabolic rate or very, very low. So obviously, you're going to manage each one of these a little bit differently, but our capnogram is going to basically tell us if something is up. So again, I look at this and I ask myself, physiologic waveform. Yeah, it doesn't really look physiologic to me. Something is kind of bizarre. I don't have a nice upstroke of dead space airway that is normally there. There's something going on. And I wouldn't memorize this, but I would think, okay, it's not physiologic. Maybe something with the equipment. Bronchospasm, perhaps, but there's a lot more sensitive things that we can look at to look at bronchospasm. But look at it. Maybe there's a problem with the circuit. Maybe there's a foreign body. Maybe there's a clinked or occluded artificial airway. Kind of non-physiologic waveform, you're looking at equipment problems primarily. A foreign body in the upper airway, you probably should have figured that out before you put the tube in. Rebreathing, again, our Hamilton ventilators are nice, but they don't give you all the scalars, the flow scalars that you would like readily available. Rebreathing is a real big problem. You can see here that you're not returning to baseline. You're not returning to baseline. You're capturing air. You're not fully ventilating, and your alveolar are getting bigger and bigger and bigger. So this is important. Your end tidals might stay the same, but for whatever reason, our waveform is looking a little different. It's still physiologic, something that we have to figure out. Okay, so rebreathing this is a pretty good example of. Endotracheal tube, again, understanding the physiology. This is a physiologic capnogram. Again, we go here and something really happens. It looks pretty physiologic. What is happening? Well, it's obviously happening further along on the breaths, on the alveolar plateau stage. What could it be? Well, this could be an inadequate seal. And again, it's difficult if you're on a helicopter or in a plane to hear a leak, for example, because it's very, very loud. This might be the first indication that, hey, maybe something's up. Maybe we have to put more saline in the cuff or something like that. Again, the important thing is not to memorize these and to say, okay, this means that, but to know, not normal, not normal, normal. Let's investigate and figure out what might be up with it. Muscle relaxant. This is quite interesting. Todd and I were involved in an Ebola project across the street with some monkeys, and they really demonstrated this remarkably well. You see this the odd time in Pediatric Patient. As you know, with muscle relaxants, you are paralyzed to the point of how many receptors you cover with succinylcholine or rocuronium. And typically we aim for around 98% paralysis. But as the paralysis weans off, you are not fully paralyzed. And so there's states of semi-paralysis. And as you're getting out of paralysis, which means basically some of the receptors that were covered are no longer covered, you get this cleft pattern that's forming here. And maybe this is really important if you have a really, really sick kid with pulmonary hypertension, you're in a helicopter, you have a really tough time assessing, you're paralyzing, and all of a sudden you see these clefts, maybe that's an indicator that you should maybe rock the kid again. Doesn't happen in all patients, but I want you to be aware of this because this could be a useful picker-upper on the helicopter. Yes?
I was doing brake relief in the unit yesterday, and there was amitriptyline overdose that was starting to lighten up and they switched him to PSV, and about every third, not every one, but every third one had a cleft in it.
That's sweet.
And increased as he got lighter and lighter.
Huh, interesting. So it all has to do with pharmacokinetics and receptor action for the paralytic. So kind of cool. So important one for you to know. Another important one for you to know is if the endotracheal tube ain't where it ought to be. Flat line is never good in medicine. Flat line's never good. And you can see here right from the beginning, I know we use a color detector. If you don't have a color detector, put an end tidal on. And again, what we're experiencing here are non-physiologic waveforms. The upstroke isn't steep enough. You don't have the alveolar plateau. Something is wrong here. So, and I bring this up, of course, this is a part of it. There's other things that you're going to test to make certain the tube is in the right position, but your end tidal, if you don't have your color detector, is golden. So when we looked at the evidence of using capnography and how it's best used, there's a few things that come out of the adult literature. And one of the things that they do is, at least in the States, is they use capnography with greater regularity than the color detector. And so they look at a tracing, because with a color detector, all we're looking at is a change from purple to yellow. We don't get a waveform. And in medicine, there's a lot of information in a waveform. So what they advocate is to use this rather than a color detector, because what you're doing is you're getting a trace in a waveform. So tube inside the trachea, which is what we want. You have a CO2 trace. If there's not a CO2 trace and the tube is in the trachea, there's obviously a bunch of things that can be wrong. More importantly, if the tube is outside the trachea, you're not going to get a CO2 trace. If you do have a CO2 trace, interestingly, I never thought about it, carbonated drinks apparently can give you a CO2 waveform, which makes sense. If you have a lot of prolonged bag valve ventilation, that makes sense as well, because when we x-ray patients after bagging them, oftentimes they have a distended abdomen. There may be CO2 in there, and they're going to artificially give you reassurance that there may be a trace, which is very important that we look at the waveform and it's a physiologic waveform, not just a number. So why is it so important for me on transport? Well, it can help us for tube placement, it can help us with dead space, it can help us with all sorts of VQ mismatches, including shunt physiology, but the most important one is this one right here. And this is, we have all been in the helicopter. The helicopter is loud, it's hostile, and it's very difficult to get a very good exam on the kids. This was a really nice study that was done on pigs. And basically what they looked at is they extubated, they did an accidental extubation on a kid, so they did a hypopharyngeal dislodgement. And they wanted to see how quickly this pig basically screamed out and said, listen, the tube is not in the right place. So they looked at SAT monitoring, and then they also looked at end tidal monitoring. There's different ways you can do side stream, you could do midstream, not really important. So when they basically caused this dislodgement to happen, for an entire 3 minutes, there were no appreciable changes on SATs. And this is consistent with humans as well. You guys are all healthy. If I pre-oxygenate you for 3 minutes and paralyze you, you will maintain your SATs above 90 for about 3 minutes. So pigs are kind of like us. The ones, of course, that we are intubating are very sick, and they desat very quickly. But a healthy human is like a healthy pig. Our SATs aren't going to have a tremendous change. However, look at how quickly our end tidal marking determined that the tube was not in the right place. At the very worst, and this was with a midstream, it took about a minute to detect that the tube was not in the right position. Okay, so we are talking at the very worst sampling 3 times quicker than the SAT monitor. Okay, so this study for me is most important reason why is that we will get into trouble with our patients with accidental intubations. They can happen at any time. We need to be alerted as quickly as possible. Your end tidal is an alert. And it doesn't matter if there's a crazy amount of dead space. With the neonates, I know sometimes that's difficult with the size of the circuit. But if your PaCO2, let's say, is 47, and sometimes we see ridiculous readings like 99 on our end tidal, it doesn't matter. You recognize that this is not physiologic. But if there's an accidental intubation, this is going to drop well before your SATs. Okay, so that's our safety net. Chest compressions is another one. There's been some really nice studies that have demonstrated quality of CPR based on end tidal. As I mentioned earlier, this is always risk and reward. Putting an airway in a kit that you're doing chest compressions is going to slow down chest compressions for that epoch while you're putting a tube in. But in the same token, it's going to give whoever's wailing on that chest an objective waveform and a number. And the literature basically demonstrates that if you are able to get end titles of 15 or higher, you're doing a pretty good job. And I think that's really, really important because there's innumerable studies that demonstrate that we do a bad job doing chest compressions. And that's not because of training. We don't do it that often. We don't do it deep enough. And then after 5-10 minutes, there's no chest compliance anymore. And it's basically like doing chest compressions on a soggy sponge or something like that. This gives us a very, very viable number to go for. And that's why I think that when you're looking at the pros and cons of intubating during CPR, the pros definitely is a physiologic waveform and a number that we can target. And why is that important? The whole reason of doing chest compressions is to essentially promote myocardial infusion or blood flow. In order for your LV to get preload, we need to get our RV function, we need to get forward flow. And our end titles are a little bit of a surrogate for forward flow from our RV, okay? Evidence. Should capnography be used? And you can read this. There's a number of fairly great evidence. Quality evidence is high in adults, so this is not a pipe dream. Capnography, again, is a tool.